So in the time that I have, I'm really going to talk about health equity and AI. I think I've had a really good time listening to the discussions thus far. And while there's been a focus on the provider side, we're going to shift gears a little bit and talk about the patient side of things. I'm with Sanofi. I'm actually new in my current role as head of North America. Prior to that, I was head of immunology. But really, our focus at Sanofi is chasing the miracles of science to improve patients' lives. That's really our sole mantra and our sole focus. And we are 90,000 people strong in over 90 countries. And that's really what we try to really focus on. So health equity is not only a passion topic for me personally, but it's also something that our company is fully committed to and trying to improve. So just a quick word on my disclosures. Though I am an employee of Sanofi, the views that I'm going to present are solely my own, and everything that I'm going to share is actually available in the public domain as well. What I'm going to do in the next 15 minutes, I think that I have allotted, is talk a little bit about health equity, talk a little bit about AI, then talk about the intersection and some challenges and what the future holds for us. So I start with this. It's a question. Do you know how much your lifespan depends on your zip code? Right now, you guys are at Columbia University, and the zip code, I believe, is 10027. You actually, and that's the Morningside Heights area, the Columbia University field, which is, I believe, named after Robert Kraft, who is the owner of the Boston Patriots. And I don't know how he got to own a field in New York, but that's a story for another day. But that field, I think the zip code is 10034, and that's where the football team for Columbia plays and the lacrosse teams play. What if I were to tell you that with those two neighborhoods, it's about a 15-minute Uber ride? What if I told you that there's a potential for an over 20-year difference in lifespan for those two zip codes? Would you believe me? Well, it's the truth. According to a study from NYU City Health Dashboard, 56 of the 500 largest cities are home to people who can expect to live at least 20 fewer years than those in other neighborhoods. In New York City, it goes up to 25 years. Do we think this is equitable, right? Should everyone have equitable access to healthcare and health outcomes? That's not a question that I'm going to answer in my presentation, but I think we can all agree that we are entering an era where we can find equitable solutions to bridge versus widen the gap in healthcare. So let's get into it. So what's health equity? Health equity, the definition is very simple. It's attaining the highest level of health for everyone. Health equity matters because it's an issue. Health equity is currently not being achieved. So let's look at how we know this to be true. So I mentioned that geography is important in determining lifespan, and we're not talking about geography in terms of one part of the country versus another part. We're talking about neighborhoods that are close together, sometimes right next to each other, right? But what's driving this? Looking at trends over a 2-decade period, nearly all metrics of health are getting worse. Self-reported health is not improving. Fewer healthy days are reported by minorities, mainly related to physical and mental health. There's worsening income disparities, and we have declining health justice. Health justice is basically a measure of the correlation of health outcomes with income, race, ethnicity, and sex. Basically, the study that's cited here was a study that was recently published a couple years ago in JAMA. The conclusion of the study was a worrisome lack of progress on health equity during the past 25 years in the United States. So 21st century problems require 21st century solutions. And in the era of AI, we can ask ourselves, how can AI be used in healthcare, and how might this be applied to achieve health equity? Current uses of AI in healthcare are related to diagnosis and treatment recommendations, patient engagement, and adherence. You've heard some of this. And of course, administrative activities, which I believe you heard earlier today, is a huge burden on the system. These are all current capabilities that are known as prescriptive analytics. There's also predictive analytics, and that's more the future of AI. And they're increasing in scale and use, and you've heard about that, and you will hear more about that. And they may take us on a journey to personalized precision medicine that may be the most beneficial advancement to achieving health equity with AI. Examples of predictive analytics that can address health equity include the ability to predict patients at highest risk of developing a chronic disease, predict treatment response, disease progression, and risk factors, and also predict and streamline resource use to improve healthcare system efficiency. So how do we use AI in pharma, which is the business that I'm in, to achieve health equity? Well, let's look at two examples. One regarding a product lifecycle management and clinical trial data, which is the gold standard for evidence-based medicine, and then another with real-world data. At Sanofi, we think that we are leading the way with our investment in AI and health equity and have developed industry-leading app called Play. This is our everything app. Play collects internal company data across various functions to deliver real-time data interactions, insights, and enables scenario planning for decision makers in the company. Play also accelerates drug discovery, enhances clinical trial design and recruitment, and improves the manufacturing and supply of medicines and vaccines. Now, we know the focus of the industry in general is really on the clinical development stages. Relevant to health equity is the use of AI in expediting the patient recruitment process for clinical trials. When we look at data from 20 years of US-based clinical trials, around 20,000 patients, the majority of trials do not report race and ethnicity enrollment data, and minorities are underrepresented in trials. In fact, so much, the FDA has started now regulating it. Insights internally at Sanofi, insights from Play are really used to improve the design and execution of clinical trials, including the selection of trial sites that can increase the representation of underrepresented communities in clinical research. So we talked about clinical development. Let's move to real-world data, which I know is also a focus of this conference. Clinical trial data are not perfect in terms of representativeness. However, real-world data can be more representative of underserved communities. How can we better leverage AI and real-world data to further achieve health equity? At Sanofi, we developed a platform called Unveiled, and that's our proprietary AI-driven real-world patient data and analytics platform. It allows us to analyze, evaluate, and apply real-world data to accelerate hypothesis generation, expedite data and insight gathering, and enable innovation and data-driven decisions, and we're very excited about it. Unveiled also allows users to evaluate key characteristics of patient subpopulations and see how they evolve over time. In this way, we use Unveiled to investigate key characteristics in populations and subpopulations with the greatest unmet needs and use this information to improve clinical trial design to address potential unmet needs. While there's a massive potential for AI to improve healthcare and health equity issues, we also must be mindful that AI is not perfect. AI models can actually perpetuate real-world inequities, resulting in algorithmic bias. Real-world consequences of inequalities and discrimination can result in resource distribution and access disparities, unequal healthcare processes, and decision-making biases. If these aren't accounted for, you produce biased data. Firstly, you can get built-in biased data and discrimination within data patterns because of iniquities from the real world. These occur because AI models analyzing medical data may reflect biases from past practices. As a result, inferences or diagnoses or prognosis may inherit these biases. Models trained on such data sets might perpetuate or magnify discriminatory structures. There are also generalization issues. For example, genome databases and biobanks frequently underrepresent individuals with limited healthcare access. And another potential source of sampling is the growing reliance on digital technologies such as smartphones for healthcare monitoring, where many people do actually, to our surprise, actually lack the ownership of smartphones. Up to 10% of certain population subgroups don't have those. AI models can also be created and deployed without consideration of bias. Prejudiced AI design and deployment can occur because of different things like power disparities in setting agendas and framing issues, meaning bias is not identified or addressed in model design. As a result, you may get unfair and exclusive design, model creation, and testing methodologies. Lastly, you may actually also get prejudiced deployment and monitoring system approaches. The issue with design and deployment can result in an injustice regarding application of AI. For example, application of AI without consideration of wealth and health disparities, neglecting and worsening of the digital divide, and negligent application of biased AI. So to summarize, there are a lot of issues with future use of AI. Here we can see some of the specific issues that we've highlighted regarding health equity that we need to have awareness of when building and applying AI models using data from clinical trials or the real world. But it's not all problems, right? So how do we address these challenges given the complexity of the subject matter? Well, we need convergence of experts in big data analytics and experts in health equity. These experts can bridge gaps in AI knowledge and strategy while also being advocates for responsible AI. We've already seen the creation of task force advocating for responsible AI and considering the potential of AI to benefit under-resourced patients. KPMG sponsored meetings in October of this year was actually health equity and the AI task force event. So where are we on this journey? Well, we've passed the point of lack of awareness about health equity issues and the potential uses of AI. We've passed also the point regarding understanding the challenges of using AI to address disparities. And I think we've now arrived at the point of generation and incorporation of guidelines and the beginnings of regulatory frameworks. So where are we heading? Well, we need to start applying the recommendations and generating evidence to either show progress or lack thereof, and then refine those approaches. We can then improve our approach and really reach health equity. The question I would like to pose to all of you is, do we think health equity should lead to an acceleration in the adoption of AI in healthcare? And I think the answer is yes, but interested to hear your thoughts on it as well. So we began with asking the question, do you know how much your lifespan depends on your zip code? I think certainly for myself, I didn't think I would know that answer, and that answer would be 20 years or more, depending on your zip code. I think that's something that we need to change, and we need to really focus on in the United States, because it's a problem that's continuing to escalate. But on a positive note, we're looking forward into the unknown. We're now entering an era where AI hopefully can help us imagine a more health equitable world for future generations, certainly for our children and our children's children. Thank you for the time. And again, I wish I was there with you, but I hope you have a wonderful conference.